Hey, hello, everybody. Welcome to the HQIC Reliability and Resilience Learning Action Series. I'm Helen Craigie, Project Manager with Convergence Health and your host for today. Just as a bit of background, in December 2023, CMS gathered all 8 of the HQIC contractors together to work to improve outcomes for patients across a broad range of quality improvement topics. This gathering was held to educate about and showcase the current work being done to improve reliability and resilience in healthcare. And so many wonderful resources were shared during that full day session that the HQIC contractors wanted to find a way to make the presentations and resources more accessible to hospitals. So this series was developed to share them in a smaller, more manageable pieces. Okay. So the HQIC Reliability and Learning Action Series is designed to educate and activate hospital leaders to the concepts and practices of resilience and high reliability in healthcare. There are 3 components to this series. So component 1, the foundational knowledge about the concepts, theories, and activities related to resilience and reliability were shared as a self-study in the webinar series flyer. You'll find it, or you can find it in links in these slides here. The first one was a recorded presentation from Dr. Oren Bootman from Jefferson Health on resiliency, engineering, and human factors as a path to high reliability organizing. And the second resource is the Leading Through Tough Times Resilience Playbook. And that's a summary of the proceedings from an international roundtable on healthcare resilience hosted by Convergence Health. Component 2 of this series is what us today. So welcome today to the second component, and it offers practical application of resilience and reliability activities at scale. And you'll be hearing from Risa Hayes and Jen Murphy, both of us HQIC experts, and I'll turn it over to them in a minute. But the third component of our series is stories from the field. So hospital case studies of reliability and resilience in action at the local level, and they'll be highlighted in our second live session on Friday, June 21st. So just a quick introduction for our speakers from Telegen. You'll be hearing first from Risa Hayes, her talk on learning from community organizing approaches to build high reliability organizations. And our second speaker is from HQI, Jen Murphy, and she'll be talking about implementing an incident decision tree. So just before we get started, before I hand it over to Risa, I just wanted to share that we encourage you to ask questions in the chat. And if we have time at the end of the talk today, we will answer them. If not, we'll follow up over email after today's session is complete. So without further ado, I'm going to hand it over to Risa.
Thank you so much. And thanks, everyone. Excited to be here with you all today. Go to the next slide, please. So I'm Risa Hayes. I work with Telegen, Quinn QIO, and with our HQIC team. And I've been with the QIO program for, gosh, almost 25 years, working on both local, regional, national projects, national support. I currently lead our patient family engagement work, as well as community collaboration, coalition building. And I'm very excited about talking to you all today and really looking at high reliability organizations and how that fits into a lot of the work I do around leadership and organizing, which in many ways is really fundamentally changed the way I do quality improvement. Next slide, please. So today, I'll be talking with you about how we can learn from and apply the practices and the tools that we use in community organizing to build high-performing teams, attract and keep talented, committed staff, and ultimately build high-reliability culture and organizations. I'll take a high-level look at the leadership practices, how those practices can be used to foster and strengthen commitment within our organizations, build effective teams, mobilize people to action, both within our organizations and in our partnerships with others. And I'll compare those practices a little bit with those of high reliability organizations and really sort of identify those similarities. And again, what tools we can use or borrow from community organizing to really help us on our high reliability journey. Next slide, please. So what is the link that I see in community organizing practices and high reliability organizations? First and foremost, community organizing is a framework of leadership practices. Ultimately, the community organizing framework that I practice myself. And these leadership practices are for both formal and informal leaders. It's really about developing leadership throughout the organization. They build both individual and collective or team capacity to do our jobs, to do them well, to continuously improve and do them better. And we build capacity by fostering leadership, again, throughout the organization, building strong relationships and commitment, both within our organizations and with our partners throughout the community, by identifying, valuing, and leveraging our team's diverse resources and skills, and constantly monitoring our progress and adjusting strategy as we learn. Hopefully you're already seeing a lot of the alignment between these practices and quality improvement, certainly, as well as high reliability. These practices are really designed to bring people together through shared interests and values, which is, again, a little bit of a shift. I think in organizations, we want our teams to align with, agree with the mission of the organization. With community organizing, that's really the foundation. We're guided by a shared mission, working on shared goals. In other words, there's a sense of team and that we are in this together. And that's really built into throughout the framework and all of the practices that I'll highlight today. Team members, all of them, are part of the design, how we are going to operate together, how we're going to build our culture. Each clearly understands their role in achieving the mission, the goals, the job that needs to be done, the importance of that role. They're accountable to each other. They share in the continuous learning and improvement of what they do together. And of course, I see great alignment between the community organizing framework, these practices, this foundation that I just described, and the pillars of high reliability organizations: leadership commitment, culture of safety, process improvement, and radical commitment to teamwork. Next slide, please. So a bit of an overview of the framework here. The organizing framework that I follow was really codified by a man, Dr. Marshall Gans, based on his many years of organizing and research as in social movements. He didn't invent these practices, but rather he really observed what was most effective to achieve the results that groups were trying to achieve in all of his years doing this kind of work, and really making effective and significant change in people's lives. I was fortunate enough to meet Dr. Gans while working on the first CMS Community Care Transitions pilot through the QIO program. The goal of that project was to test an evidence-based care transition intervention to see if we could implement that in a small community of providers, one hospital, one nursing home, one home health, and one physician office who shared a population of patients. Seemed relatively straightforward. Of course, we approached it with a quality improvement lens, armed with our quality improvement skills. And we quickly realized that we needed, that something was missing. It wasn't just as easy as approaching this as just another quality improvement project. Not that quality improvement projects or process improvement is easy per se, but we needed a little bit more than our QI expertise. And as I said, we were lucky enough to meet Marshall Gans, who introduced us to community organizing. After studying with him and starting to apply this to our work in healthcare quality improvement, we actually received permission from him to adapt and tailor this specifically to quality improvement. And as I said, it's really become a foundational part of how we do our work. The practices within this framework are really all geared toward developing leadership at all levels. Leadership is a mindset, recognizing and claiming our own leadership to carry out our part of the whole. So regardless of titles, job roles and descriptions, but understanding I am leading change. I am leading my part of this process for caring for our patients, for improving our organization, helping each other to achieve the shared purpose. We are in this together. We make a difference together, and we each have an important role to play. The stakes are very high in community organizing efforts and certainly in healthcare. Again, huge alignment there. The stakes are very high and the outcome is absolutely uncertain, and this requires a lot of commitment. It makes it crucial to create a culture of physical and emotional or psychological safety that really brings out the best in us. It really calls forth the best of what we have to give, individually and as a team. Effective organizing can't rely on command and control, but rather recruiting and developing an empowered, motivated team bravely facing challenges together. And we bring people together, labeled here as the constituency, not only because of their skills, these can be taught, of course, but really based on that shared vision, values, the interest, the bigger picture. I'll walk through each of these very, very briefly and a little bit more as we go on. And even though I talk about these in order, this is obviously not a linear process. It's a constant practice with constant improvement. The first practice you see here is shared story. This is really about understanding and articulating the why. My own story. Why do I care? What brought me to this organization, to this work, beyond the paycheck, beyond the bottom line? The story of our community, those that we serve, the story of the future that we're working to create. That sounds very lofty, and it is, but that applies to both for this patient that we're caring for right now, as well as the health of the community. Second, building and strengthening shared commitment to the organization, commitment to one another. And that's really very important. Commitment to each other. Relationships are ultimately rooted in our commitments that we make, that people make to each other, not simply a goal, or a task, or an issue, or an organization. Thirdly, putting structures in place to actually work together effectively. It creates clarity of roles, responsibilities, communication processes, etc. Brene Brown says, clear is kind, unclear is unkind. I think of this constantly when things are going wrong. What is clear? What is unclear? Creating safety, both physical, psychological safety. People feel a sense of agency. They understand their role. They feel like they have a voice. Efficiency and effectiveness. And a lot of this work under structures really comes from researchers who have studied high-performing teams. Fourth, developing strategy together, a strategy that the team believes in and is willing to try, trust, and improve. Requires rapid cycle improvement, observing and tracking processes and outcomes, evaluating effectiveness based on the data, and acting, making adjustments as needed based on those findings. And lastly, taking coordinated, effective action. Again, this framework is about creating both the systems and the culture that enable great teams and high performance, high reliability. Next slide. So organizing is ultimately about people coming together to create power to make change. This applies to our organizations just as much as it does to social movements, really. And again, I see so much alignment here. Power, when we really look at that word, what does that mean? It's really the ability to take action to achieve goals. We are applying these practices to grow our capacity to make things happen, again, both individually and collectively. In organizing, we recognize that power comes from our people, developing leadership among people at all levels, building community through that leadership in order to create change, to get our jobs done, essentially, and specifically building power with. building power together, that collaborative capacity, both within our teams and organizations, as well as with other community organizations, other providers that we need to work with to really care for our patients. Another speaker from sessions that we did in December, Dr. Cohen actually talked about collaborative just culture. And that's really where I see building power with really comes in. It fosters trust, safety, personal agency, certainly diversity, equity, and inclusion, commitment, and resilience. And next slide, please. So there's a lot on this slide. This is essentially within each of these practices, there are many tools that we use. I'm just going to highlight a few. And we are absolutely here to answer questions and provide assistance, coaching, information. If others look interesting to you, please just let us know. So I'll just go a few of these, starting on the next slide with shared story. Our teacher, Dr. Gans, really talked about the 3 stories that every leader must tell. And again, this is really sort of that key first step in really building culture together as a team, strong commitment. Firstly, understanding why you care. Why are you called to do this work, whatever that is for you? Why do you really care beyond your resume, your education, all of that? Peel away the onion. Why do I care about this? One of my favorite quotes is, people don't care what you know until they know why you care. And that's really what I draw on here. The second story, the story of us. Again, that's that collective, that story of the community together as a team, but also those that you're caring for, those that we serve. What are that collective experience? What's the shared hardship? What's the health of this community? And how is my organization, my team, trying to help improve the health? The story of now is really, that's where we get into what's the future that we're trying to create. Again, both with the patient that we may be caring for who's in front of us right in the moment, as well as overall the bigger picture. How are we trying to improve health, healthcare, team culture? Next slide. So shared commitment. This tool is the mapping actors, and we often use this very much when we are building coalitions, collaborations, collaborative capacity across organizations, but it's also a very effective tool within your teams, within your organization. I always say, start with yourselves. What is it that you're working on? If you're working towards something, you're trying to improve something, well, what's the challenge that you're facing right now? Sometimes we call that the nightmare of the current state. And what are you working towards? What's the dream future? So think about who's impacted, who's harmed, who benefits, who wants the change. And you start sort of mapping not only the people, the actors, but also the resources. And understanding that is also what's leading to connections, aligning with one another, and again, building our power, building a leadership team based on commitment, skills, who do we want to help us lead whatever the effort is? Where do we find our support? This is both within our organizations or community, but outside of it. This is a great tool actually for emergency preparedness as well, by the way. Competition. Are there organizations or teams that are competing with us? They want the same thing. We have the same goal, but are we competing with each other for resources? And then opposition. Is there someone or something that actually does not want what we want? Again, we do this a lot with coalitions, but this can be very effective, again, to really understand what we're trying to do, what we're up against, where our resources and supports are, and how do we build that collaborative capacity together. Next slide. So the next practice of creating structure, the structures that really help a group of people work together effectively. And again, all of this comes from the researchers who have studied teams for decades, actually, essentially these ingredients of what they find to be the highest performing teams. bounded, stable, interdependent teams. If people are coming and going, you're never going to have a stable team. So how do we create that? They need to have the essential resources, skills to get the job done, clear, compelling purpose. Both my role, my job today, my role overall, but also what's the big picture. They need to understand their work. It's challenging and they're compelled. It feels good to have a job well done and be doing it with the team. Those enabling structures for how the team functions. I see this skipped quite frequently, especially in coalitions, but even within an organization, somebodies may have created a bunch of rules and policies that nobody had nobody had input on, or it's been so long that they just are handed down. So how do we really make those work? And they are agreements rather than rules from above. And that's, again, something that's been found to be much more effective. And then, of course, that constant process clarification, process improvement, everyone understanding their roles and having interdependent roles. What are the swim lanes and how do we not only stay within our lanes, but make sure that we're working together effectively? And there's so much more we could say about this, but let's go ahead and go on to the next slide. So there's many tools under shared strategy. I almost always start with what we call the organizing statement. And again, this is a great tool that you can use within your organizations, your teams, across organizations with collaborative partners and projects. Who are you organizing? It's a slightly different way of thinking about your work. And I always say, start with whichever part you know. Who are we organizing? Who are we bringing together to do the work that we're trying to do? The what, that's your measurable aim. You need to know if you're successful, by how, what tactics are you employing to get there? And in order to what's your motivating vision? That's what gets at the heart of the work. You can't always speak only in program jargon and numbers, but you need the heart, and vice versa. You may be really good at the heart of the work, but not necessarily have those measurable aims that show you, yes, you've succeeded. And then of course, by when. And next slide. Shared action. This is really kind of bringing all the practices together. And again, there's so much that could be said here, but ultimately it comes down to this framework is about really employing the head and the heart, the strategy and the narrative, the how and the why to mobilize action, the head, the heart, and the hands. And all of these practices are really geared towards that in order to create the culture that I talked about earlier. And we truly do need both to inspire action. Quite often I see that we live very much in the strategy or the head of the work. And we often see that we think, oh, people aren't motivated. They don't really care. They're not committed to it. And in that case, sometimes it's because we sort of forget about the heart of the work or vice versa. And next slide. I want to leave you with there's many tools that you can use here, but thinking about how do we actually, what actions can you take? What tools can you use tomorrow, for instance? And we use this set of steps often for one-to-one meetings, one-to-one interactions with people, but we often apply it to our agenda so that we are using action-driven relational agendas. What does that mean? So first and foremost, that first step, selection and attention. How are we actually selecting people? Getting to know a little bit about them. What's important in how we select people? Again, kind of goes back to narrative, understanding that. Why do you care? What's important? What connects us to one another? Getting people's attention, the art of promotion. I feel like I could do a whole series on how do we promote one another, connect one another. When we apply that to a group meeting, I don't know about you all, but how many meetings have we been in where you're not quite sure, why am I here exactly, other than I'm in the department or something, but there's not necessarily a connection to say, why was I chosen? specifically me. And I've really made it a point to add that to my agendas now so that people know you were actually selected intentionally. You're not just here because you're a warm body. Clearly stating the purpose of the meeting, whatever that is, to explore, and that's fairly standard. But also integrating into that opportunity to explore and exchange based on ideas, that leadership that we're trying to foster throughout the organization, the teams, and even in collaboration, so that you're getting so much more than just updating people on, whatever the new initiative. So it's a two-way conversation, and oftentimes it really results in much richer ideas and commitment, leaving with commitment, leaving in action that's very specific, and we know exactly what we're committing to and when we're committing to do it. So again, there's so much more that we can go into on this, but just let us know if you're interested. And next slide, leaving you with a question. I'd love to know, and I'm pretty sure you can chat in. I'd love to hear one insight that you gained from this, or idea, or inspiration, or connection that you made. As I said, I'm very passionate about this work, and I see the connections, and I always learn something when I hear what connected for you, what insights do you have? And if there's one action that you want to take based on what you've heard today, even if it's not exactly anything that I talked about, but if it inspired something, I'd love to hear about it from you. And with that, I will say thank you very much. And you can move to the last slide, which is just my thank you slide.
Thank you so much, Risa. Sorry, I was just unmuting myself there. Thank you so much for this clear and powerful presentation. Just such a window into so much information. We just thank you so much. Quick question in the slide about whether we'll have these slides to use as a roadmap, and absolutely we'll share these slides, and you'll see that Risa's information's in here as well, and I'm sure you'll be able to reach out as well for more questions, or as Risa said, she's inspired by the different work that folks are doing. So just want to thank you so much, Risa. This was fantastic. And we'll move on to our second presentation. I'm going to introduce to you again Jen Murphy, who's talking about implementing an incident decision tree. And Jen, I see you unmuted yourself. I know she was having some internet stability issues, so I believe you'll be off camera, but take it away, Jen.
Yes, thank you. Due to some inclement weather in my area, I'm not trusting my home internet today. So thank you very much. And definitely a tough act to follow there going after Risa. Next slide, please. As you said, my name is Jen Murphy. I am with Health Quality Innovators, or HQI. We are an HQIC as well as a QuinnQIO based out of Richmond, Virginia, but we work all across the country. I've been with the company a little under 2 years, and prior to that, most of my work was in patient safety, quality, and high reliability. So hoping to share some of my knowledge with you all today. Next slide. So the objectives for my presentation specifically are to define just culture and fair accountability, describe the components of an incident decision tree, and to review best practices for implementing an incident decision tree within your organization. Next slide. So whether it's based on your own experience or listening to some of the presentations that Helen went over that were pre-recorded, I hope that most of you are pretty familiar already with the high reliability principles that were demonstrated in the Wyke and Sutcliffe book. This book has been out for a while, and they're broken into principles of anticipation and principles of containment. But what I'm going to talk about today is that it's not just enough to know these principles or understand what they look like in action. They really only work well in your organization if you have a culture that is fair and just. And so we're going to talk a little bit more about that. And you heard Risa mentioned that in her presentation, that we really need to make sure that we're fostering trust and psychological safety for these principles to really be, well executed in your organizations. Next slide, please. I love this quote from Lucian Leape. It is a slightly dated right now, but it's from his testimony to Congress, I think in the early 2000s. And it really speaks to what has been the historical challenge for the healthcare industry. And that is that we have, punished people for making mistakes. And I think it came from the right intent. We're dealing with people's literally life and death. And, so it felt like we had to be extreme, but really it's not helping us move forward in terms of error prevention. So it's been a challenge to truly be able to embrace high reliability principles when we're still being very punitive. So having that open and fair culture that creates an atmosphere where where your staff feel comfortable speaking up is how we can really detect and fix system mistakes. Next slide, please. So in a just culture, we're really trying to break this cycle of punishment and errors repeating. We want to have a thinking where we embrace that systems problems are really the main causes, not people problems. A just culture encourages the reporting and learning from errors. It's very much founded in learning and education. The focus is on fixing issues, or as most of us are familiar with, the holes in the Swiss cheese, so that we can prevent future harm. And most importantly, and I'll talk about this a little bit more, it really focuses on intent and behaviors and not necessarily just the outcomes of the events. So we're going to talk about that a little bit more in the coming slides. Next slide, please. So first off, knowing where your organization is starting from in terms of having a fair and just culture is important. And most of the, if not all, of the current safety culture surveys available today do have questions about this. The ones I have on the slide are from AHRQ, their survey of patient safety. And this is specifically the hospital one, but if you have a more integrated organization, they do have versions of this survey for other settings as well. And this is specifically from their non-punitive response to error section. So you can see that this looks at staff's perceptions of how errors are discussed and responded to by their leaders as well as by the organization. Now, thinking back on Dr. Leape's quote, it's really not uncommon for your organization, especially if you're just starting off on a high reliability journey, to score low in this section of questions. And when you look at the benchmarking data, it's not a high scoring composite of questions, across the board. So just keep that in mind and, don't be too hard on yourselves. But it is also important to know that this is a key driver for other areas of the survey, meaning that when you have an improvement in this particular area and staff are feeling that it's less punitive and it's a safer psychological environment for them, you are going to see improvement across many other areas of your safety culture. For example, event reporting. So if you're not sure what your survey results are, and this isn't something that most organizations do annually, maybe every 2 years, it might be part of a larger employee engagement survey, but I encourage you to make sure that you find out what your results are and where do you benchmark. And Dr. Gutman talks about this in his recorded presentation as well. Particularly important to also be able to get more granular unit or department level data from these surveys, because that can also show you where you have perhaps micro cultures that need a little more care and attention, as well as the entire organization. Next slide, please. All right, so next we're going to talk about fair accountability. And if you look across all of the leaders in your organization and you put them in one of these buckets, it'd be kind of a middle, I wouldn't say a bell curve, but you'd have people somewhere on this spectrum. And it's important that we think about accountability that way and the impact of the different types of accountability on your organization. So to the far right, we have that traditional healthcare industry blame and shame approach. It's pretty self-explanatory, but this is when we blame the person for the error. It may not even be investigated to see what really happened. We don't learn from it, and we really foster shame and guilt among our staff. So as you can imagine, this does not support speaking up, and these systems issues continue to go unreported and unresolved. Now, on the left, we have the blameless culture. And it may feel a little counterintuitive, but a blameless culture is just as detrimental to safety in an organization. Because what happens in this scenario is no one's ever held accountable, even maybe when they should be. And so those errors continue to happen because people become apathetic or sort of have a so what, like, why am I going to say something? Because nothing ever changes. And so you have the same result of systems issues not being resolved. What you really want to strive for is to have that pendulum kind of sitting right in the middle, where we have a fair response to errors that holds employees accountable for their actions. Next slide. So fair accountability is about taking the appropriate action in response to the error based on the behaviors and not just based on the outcome. So this could include formal disciplinary action, but it might not. We're going to talk about that. And it also means that the actions are taken at appropriate times and after all of the facts are gathered and reviewed. So we're not just having sort of a shotgun, approach, like this happened, so this has to be the reaction. We want to make sure that we're timely. You don't want to leave your employees hanging out there after there's been an event. That's not fair to them either, but you do want to make sure that you take the time to really gather information and investigate what happened. It also doesn't mean that events aren't going to be reported outside of your organization. We all know that there are certain state laws or regulatory or licensing body statutes that require certain kinds of events to be reported. And so knowing what that is in your state where you operate is important, and also making sure that your employees understand that while we may have to report this to the nursing board, for example, here's how we're going to handle it internally after our investigation. So just keeping those things in mind. Next slide, please. So a little bit more about what I mean when I say looking at the behavior versus the outcome. And what it comes down to is intentionality. What did that person intend to do? When a truly unintended human error occurs, the correct thing is not to punish the person. They didn't intend to cause the error. The situation that they're in or the system caused them to experience an error. And I use that language, experiencing an error, very intentionally as well. They were put in a situation where this was going to be the outcome. So here, what it's better to do is to actually console the person. They are going to feel bad enough. So we really want to make sure that we're taking care of them, of their mental health, giving them time to process what happened, and making sure, above all, that they're safe to come back and care for patients following these types of events. And it doesn't have to be necessarily something that caused, severe harm or death. Someone who has a near miss with a medication, that can shake them up just as much as a more severe event. So when you get into more of at-risk or blatantly reckless behavior, that's where things start to change, and where coaching, counseling, or possibly even disciplinary action would be appropriate based on the details of the event. And this is where the incident decision tree really becomes a tool to help your leaders be more objective in determining this and how to respond. Next slide, please. All right, so the incident decision tree is largely based on the work of James Reason. It accepts the fact that we're fallible. We are humans. We are going to make errors. We are going to experience errors. It helps you sort through that intentionality and the riskiness of the actions that were taken. And it helps you to determine when you need to use disciplinary action versus counseling, coaching, or consoling. Next slide, please. So I recognize this is kind of small on the screen, but there are lots of templates. If you Google incident decision tree, it's also referred to as a just culture algorithm or a performance management tree. There are lots of examples out there from very reputable organizations. I believe the IHI has a whole packet on this as well. So you can take a look at this, but we are going to go through each section in detail. I'll touch on this at the end, but I discourage you from just taking one that you find online and implementing it in an off-the-shelf approach. And we'll talk about the reasons why for that later. All right, next slide. So the decision tree is broken into 4 parts: the deliberate harm test, the incapacity test, the foresight test, and the substitution test. So we're going to go through each one of those. Next slide, please. So the deliberate harm test is where we first look at intentionality. So were the actions of the individuals intended? Were the consequences of that action also intended? And if so, we have an intentional malicious act. These are almost always going to be criminal in nature. In my 15 years of using this tool, I have never had an event that went straight down yes on all these questions. It is extremely, extremely uncommon in healthcare that someone intends to cause harm, intends to have those consequences. But we do account for it on here because, you hear those angel of death stories in the news every once in a while. Okay. But what's more likely is that the action may have been intended, but not the consequence. So for example, somebody who doesn't intentionally foam their hands or wash their hands when they go into a patient's room. They made this decision consciously not to do that, but they didn't intend for the patient to end up with an infection. So that's the consequence. So that's more commonly what we see with this first deliberate harm test. Next slide, please. With the incapacity test, what we are looking to do is eliminate if there were any medical conditions or substance abuse issues, which is this in and of itself a medical condition that may have impacted the decision making of the individual. Because if that's the case, it needs to go down its own path and be handled separately. So for example, I had a situation with a nurse who was a newly diagnosed diabetic, and she became very hypoglycemic during her shift. She was observed by others as being very confused, and subsequently she did have a medication error. Now the patient was fine, but after we reviewed everything and went through these questions, this was not her fault. It was an error that was related to her learning how to manage her new diagnosis. And so it was more about consoling and coaching her and a little bit of job accommodation. So we got her some additional education around her diabetes and made sure that she had a schedule that allowed her to take breaks at the right periods to check her blood sugar and eat or take medication as needed. So that's an example of where a medical condition would be at play. And again, the correct thing there is not to punish her for that medication error. It's to fix the underlying issues and make sure that that doesn't happen again. Next slide, please. All right, the foresight test looks at whether there were any tools, policies, or other resources that an individual had available that they should have used to make that decision before taking action to make sure that they did the correct thing. So we look first at, did they depart from existing policies and procedures? And then looking at, were the policies and procedures available, workable, intelligible, correct, and in routine use? I know there's a lot in that box. It's a really important question on this tool because you need to be able to say yes to all those things. I can't tell you how many times I've walked through this with a leader and they'd say, well, there was a policy on that. And I'd say, okay, well, where is that policy? And it takes them, 15 clicks on the internet to find it, or they can't find it and the paper copy is 10 years old and it's not the current policy. That is not an available, workable, routine use policy. So it's important to really dig into all the aspects of that question. And it is where leaders often get stuck, and because it forces them to be really honest with what's going on in their area and how they are really consistently holding all of their employees accountable to the same policy. So a good example of this is hand hygiene policies. Most, if not all of you, probably have something in your hand hygiene policies about not permitting artificial nails or nail polish, but this is very often an overlooked and unenforced policy. So it's not fair to hold one employee accountable to not following that policy, and when others are not being held accountable to it on a regular basis. So that's really what we're getting at with the foresight test is, should they have used things? Were there things available for them to mitigate the risk? Or did they bypass all of that, knowingly and have an at-risk behavior? Next slide, please. Okay, so last we have the substitution test. And this is looking at if we changed, the things in the situation just slightly, would there still have been an error that occurred? And we look at, was the person trained appropriately? Were they selected appropriately for this performance or for this job and role? So, you may even be getting into your HR policies there. Were there any mitigating circumstances? And also, what would a peer do? And you need to make sure that when you're looking at the peer question, that this is someone in the same role with the same level of education, training, and experience. You don't want to compare a senior critical care nurse with 25 years of experience to a new grad nurse who is fresh off of orientation. They may be peers in that they work in the same unit, but they are not peers in terms of their education, training, and experience, and therefore very likely might make different decisions. The other thing to keep in mind is with mitigating circumstances, it really needs to be something that would have impacted everyone. So a good example of this is like tardiness. You have somebody that's consistently late versus everyone was late today for their shift because there was a huge accident and both sides of the highway were shut down. That's a mitigating circumstance. The person that's consistently tardy every day, that, their lateness or their reasons for their lateness are likely not mitigating circumstances. They may think they are, but they probably are not. So let's look at an example real quick. And you can feel free in the chat. Oh, yes, thank you. Next slide. You can feel free in the chat to put down whether you think this was an unintended human error, at risk, or reckless. And then I'll show you kind of where we would land with that. So a nurse is administering a high-risk medication to a patient and does not adhere to the 2-nurse check. The patient experiences an adverse event and it is discovered that an incorrect dose was given. After investigating, the nurse manager discovers 2 nurse checks are routinely not being conducted by other nurses on that unit due to low staffing. It's been hard to find another nurse who wasn't busy and still administer medications on time. So let's see if anybody has any thoughts in the chat here. Just give it a second. So unintended human error, at risk, or reckless. All right, I see one from reckless, at risk, reckless. All right, let's see what we come up with here. Next slide. Okay, so first we're going to talk about the actions where they intended. So the action that we're talking about here is not doing the check. And yes, that action was intended. They knowingly did it. Were the consequences intended? No. Then we go to incapacity. Did the person have a suspected substance abuse or medical condition? From the little information I've given you, no. So we would go down to foresight. Did they depart from existing policies? Yes. But then were those policies and procedures available, workable, intelligible, correct, and in routine use? In this case, from what I've told you, they were not in routine use and they were not being monitored. So we would move away from at risk, if anybody said that, and move on to the substitution test, where we're asking, would a peer do the same thing? And we have that information as well, that yes, as the nurse manager talks around, everyone's been skipping this step. So we actually end up in it being a human error. So just to give you kind of an example, and I know this was, 30,000 foot, not a very detailed one, but, just to give you an example of how you would walk through the decision tree. All right, next slide. So lastly, I just want to touch on how you would implement this in your organization. And I mentioned you don't want to just take one that you find online and say, hey, this is our tool. You really need to have a thoughtful planning, training, and implementation. So for the planning phase, establishing that interprofessional team with a C-suite champion, your HR, quality and safety, definitely want to include your medical staff. Then reviewing all of your policies that speak to disciplinary action and making sure this is referenced, and revising them as needed, and making sure that it is accounted for your medical staff as well. Anybody that's credentialed, they're governed by the bylaws, not necessarily by your HR policies and procedures. So how is this going to play out with your medical staff? That's a really important part of this. Next slide, please. Once you've done all of that work, then tweaking that decision tree so it reflects your current policies, and developing one specific to your organization. Using some of your historical events to test it. How would this play out using this tool? Doing that, of course, maintaining confidentiality of those involved in the events, but really, put the pedal to the metal and see how it would work in your organization. Next, you're going to identify champions to help test it live, sort of do a pilot. And this is, again, where your safety survey can really help you to identify both leaders that are, at the ends of that accountability spectrum, as well as ones that are maybe in the middle. You want to get a good cross section of your leaders there to test it. Next slide, please. So after you identify those champions, you can go about piloting it. I would recommend this actually go for a month or two just to get a good, cross section of examples, and make sure that you're looking at both clinical and non-clinical areas. Then you can move to training your leadership, and also staff education. While this is a leadership tool, it is very, very important in your implementation that the organization as a whole knows that this tool exists and that this is how they're going to be, not evaluated, but this is how things are going to be addressed going forward. It goes a long way to improving that culture score when they know that, there's a tool that all leaders are expected to use. Then you're going to want to launch and monitor it. Traditionally, the way that we've monitored the implementation is through looking at your event reporting system. In organizations I've been at, we actually added a field in our event reporting system on the manager review to have them select, did you run this event through the incident decision tree? And then we also, all of these incident decision trees should include consulting HR when appropriate. So we tracked the number of usages, consultations to HR as another implementation metric for this tool. So I know that was a little fast there at the end, but want to leave time for questions for either myself or Risa. If you go to the next slide, we do have a module on this on our resource center for HQI. So when you get the link for this, or when you get the slides, those links should work if you'd like to learn more about that. And on the last slide is my contact information as well, should you have any additional questions, or are maybe in the process or looking to implement an incident decision tree in your organizations. Thank you.
Thank you so much, Jen. Such practical and level-headed application of resiliency and reliability. Thank you so much for sharing. That was incredible. As you said, we have a few minutes left for questions. We would love to open it up to anybody. You're welcome to use the chat. You're welcome to unmute yourself and ask either Jen or Risa any questions that came up for you along the way. Just give everybody a second. Well, folks are thinking, just wanted to remind you about our next session on the 21st. Session 2 is on the 21st of June. It's a Friday, and we will have more folks coming in, and I'm talking about practical applications of resiliency and reliability. Can I go back to slide 42? Sure, Kelly, hold on. You're welcome to unmute yourself, Kelly, if you have a question, or use the chat, either way.
Was there a question on that slide, or just wanted to go back to it for a second?
Hi there, that's Kelly. Can you hear me?
Yeah, go ahead, Kelly.
Hey, okay, thank you. I saw, at the bottom, identify champions, utilize safety survey results to identify leaders. So how would I put that into use? Because, the safe or are you even talking about the culture of safety survey?
Yes. So yes, great question. I'm talking about the culture of safety survey.
Okay,
And, depending on your vendor or how you administer it, I would hope you have at least department level data. You may not
yes,
have.
of course,
Okay, great.
yes.
So breaking that department data down and looking at your questions specifically that deal with just culture or non-punitive response to errors, like I mentioned, you're going to see that your areas are across the board. So you might want to find a few folks that scored really high in that composite.
Got it, okay.
Some that scored a little lower. I don't think I'm in the minority when I say this, but when you're doing an improvement project or a change management project, it's important to have some of those naysayers, really run it through its paces and hear, well, what are going to be the barriers that people have? Sometimes they have really good findings, and it'll go a long way to helping you craft that leadership and education for when you get to the training sessions.
Okay, thank you so much. That cleared up my
Yeah,
questions.
no problem.
Thanks.
Thanks, Kelly. Any other questions? Stop it there. I just wanted to thank so much Risa and Jen for coming today and speaking with everybody. As folks are asking, yes, the slides will be available. We'll send them as a follow-up to today's session. Such great information in there and so practical and useful. So we look forward to sharing that with you. And please don't hesitate to reach out if you have questions for Risa or Jen that come up in the future. We're here for you. Just send an email to myself or Risa or Jen, and we'll be in touch to help you out. Thanks everybody for coming today. Again, thank you to our speakers. Everybody have a great rest of your day. Thank you so much.